Hi, guys, and welcome to this episode of the Seconds Count podcast. I'm joined with Natasha, who is a newly qualified RN in urology, is it? Or
Nephrology.
nephrology, sorry.
Yeah.
Um, so, introduce yourself, Natasha. So, what got you into nursing?
The pandemic really. I think before the pandemic, I was working in business in a very big corporate company, and I was really miserable. Just absolutely bored, mindless, long hours, and not really paid me reflecting. I didn't really feel I was sort of achieving anything, and couldn't see sort of where my career would go. Pandemic happened. I got told I needed a shield and got furloughed, and all of a sudden had quite a long time of being paid at home to be at home and sort of figure out what I wanted to do with my life. Um, and during that time, one of my closest friends was also shielding because she was having chemotherapy. So we'd spend every day on the phone, and she kept doing millions of quizzes with me. And she goes, "Have you thought about care?" And I thought, well, yeah. I mean, I've got special needs siblings, and I've done care sort of informally my whole life. And with that, my husband got an offer for teaching in Norfolk. We moved up to Norfolk, and I started care. And from working in a home for vulnerable adults and adults with learning disabilities, extra needs, mental health, Down syndrome, everything and anything, I really sort of found my calling. And after that, it's okay, well, what do I want to do with this? Do I want to stay working in care? Do I want to be a care manager? Or do I want to go into nursing? So I reached out to people I knew, people I'd gone to school with, friends of my mum and who worked in care, worked as care managers, owned care homes, worked at nurses, and sort of did a lot of questions with them, a lot of tell me everything you can, did a lot of research, and sort of decided care home manager wasn't for me. I really enjoy being person facing and patient facing, and from that thought nursing is the best fit for my qualities, what I enjoy. um, Nursing really is what I wanted. So I did a lot of thought, a lot of research. I think I've still got my notebooks somewhere for all the research I did. Um, and I thought I'm going to try it because what could go wrong? I don't enjoy it. I go back to care, and I've never looked back. And it is the best decision I made.
So, you went from care to straight to university. Was you full-time student or?
Yeah, yeah. So
Okay.
I was a full-time student. I did a year and a half of care where I did different types of care. So I did home to home care, palliative care, high needs care, high security care. I did everything I could to really get the experience of what I wanted. I found palliative care was one of my favourites. I think there's something truly beautiful about being with a person in their last few days and just making them as comfortable as you can be, and really forgetting about all the rules you're told and all the sort of guidelines we have to go by as health professionals, and just doing what's best for them. So I remember one gentleman who he was a GP, and he just thought, I've never dyed my hair before. I've got weeks left to live. I want to dye my hair bright pink. So we did. And he loved it. And it's those little memories that stuck with me. And I know it stuck with their family. And I think it's really beautiful. So I know I made the right decision there as well. So yeah, then I went to uni, full time student, worked alongside as well. Um, because of the current situation in the UK, it's impossible to be a student nurse and not work. Um, and then from that, I started my RCN duties as well. So it's been a
So,
whirlwind.
how did you find going back to uni as obviously as a mature student? How did you find the course support you at all?
Yeah, so my uni are really good, and they have like a mature students network, and I was dreading it. I was 27 when I started my course, but the first 3 weeks, when you get to know everyone, I was actually learning from home because I'd had surgery on my leg to have the metal implants removed, which had been planned a year in advance. So I was like, I don't want to sacrifice this because I know having that metal taken out is going to make my life so much better. My legs will be better. I'm more physically able to do the nursing job. So in those first 3 weeks, everyone's getting to know each other. I was like, "Hi from home. I've had surgery." Um, but actually, I wasn't a mature student compared to other nurses on my course. I had people in their 50s and late 60s, with someone who was once a lecturer in English language and literature is now a trained mental health nurse. And if anything, I think going into nursing after taking a gap year and being a bit older is a lot better than going straight from uni. I think you have more life skills and life experience that really build you up for this kind of course. I mean, for me, this is my third degree. My first degree was drama, and I started out at 19, and I spent most of it drunk. You know, you enjoy that freshers feeling. You enjoy that. Oh, I'm 19 with all this income coming in, and yes, I've got a degree to do, but I still want to go out partying. Where when you do something like nursing or anything medical based, you need to be focused. You can't be going out partying the night before and rocking up to a lecture at 9 a.m. because you won't absorb what you need to absorb.
Of course. So, placement wise, how did you find placement
I
as a student
think
nurse?
majority of them I loved. I had one or two where I cried. I have a reasonable adjustment plan in place. So for me, I have placements close to home and certain restrictions. So I don't do respiratory patients because of how poorly my asthma gets with COVID and pneumonia and TB, anything like that. It's just too much of a risk. My first placement was at James Paget in endoscopy, and I loved it. I absolutely adored it. I thought, oh my God, this is amazing. I'm really sort of science and research based, so I love being able to see everything on the screens. And the doctors would draw me little diagrams to show what I was looking for on the whiteboard, and I loved that. And they're very much like, just because you're a nurse doesn't mean we're not going to ask you questions. And they were very welcoming, and we got to be involved. And um, they would show me all the research they were working on and stuff like that. So I really enjoyed it. And then my second placement was community, which I knew I wasn't a community nurse, but again, I still enjoyed it. You learn a lot about wound care. You see a lot of gnarly stuff. I remember seeing necrotic leg ulcers, which had gone through bone and past. Um, I then did orthopedics, which I didn't enjoy. I learned a lot. It wasn't for me. I really struggled with it. Cried quite a bit. It was my first time being on a ward as well, so I didn't know what to expect. I didn't know really what to do or what to expect. And I think at that point as well, I was like questioning, you get to second year, you get the second year blues, and I was questioning, is this for me? Have I made the right decision? I was poorly myself. And then I started my nephrology rotation and absolutely fell in love with ward work. I said to my clinical assessor on the first day, I'm not a hospital nurse. I want to work in a GB surgery. I'm just here to get the hours. And obviously now she's one of my line managers, and she said it quite often. She goes, "So you're a GP nurse?" I'm like, "Yeah, okay, thanks." Um, and I think her words to me was just go in with an open mind, and you never know what you'll experience. So for me, I think I got all of that and more, and I had a supportive team. I got to see all sorts. With nephrology, you do see all sorts because even though it's renal, it's the whole body. Um, really, really loved it. And then continued HA-ing with them until I graduated because I knew that I wanted a job with them. And I thought if I stay and if I keep HA-ing, they're not going to forget me. They're going to remember my face. They're going to see how good I can be. And it worked. I got the job. And then in third year, I had my research placement, which was a chosen placement, and it was amazing. And I loved it. And I was based in a community doing research, which I didn't even think was a thing. And again, I learned a lot. I got my NHIR account, and I've got like my basic certificates for that. And it's something that I'm still keening. And I know eventually when I start to slow down, I want to look at research and I still want to go into research. And my final placement was neurology, which again, really enjoyed. I have a family history of neurology. My sister has MS, my brother's got FND. My family on a whole, all genetic wise, we carry the cluster DNA for autoimmune conditions, so very neurology based. And I learned a lot. I think I just struggled with how that ward works because there was a lot of team members there who've been there 30 plus years and weren't always the most welcoming. And it's something I put in my feedback. And for me, being my final placement, being given the keys and be like, go do a drug round, for me was really hard to sort of comprehend. So I thought, well, I'm still a student, not got a code, but okay. But yeah, I enjoyed placements. I think, and I say this all the time, I say this to new students, you need a bad placement to help you understand the good placements. You have to take the good with the bad. If you love every single placement, you're not doing something right. You need to know, you need to experience the bad. You need to experience the bad nursing. You need to think, okay, this nurse did that. I know that I don't want to do that when I'm a nurse, and that will help build who you are. And again, it's all vital, and you learn a lot from all placements.
So we mentioned before, second year was quite hard for you. Is there any sort of single event that did that for you? Or was it multiple?
It was multiple, I think. So towards the end of my first year, like I said, my little sister, when she was 17, uh, just slowly started losing the capability of like moving her body. So it was like one of her legs and the other leg and her arms. And we were thinking, what is going on? My mum took her to A&E during the doctor strikes. And the nurse who picked her case saw her. She said, "Oh, this is easy. We'll do an X-ray." Nothing was there. So they turned around and said, "Oh, it's because she's autistic. It's her autism just telling her she can't move her body." And I was a bit like, That's not a thing. That doesn't make sense." But my sister wanted to go home. My mum was tired, and I was like, "Okay." She took her home. 6 weeks later, she was completely paralysed. The community physio came to see her and called the ambulance. And I was in Brighton at the RTN Congress when I got the phone call from mum saying she's been rushed to hospital. They think it's either a tumour or something else. I was like, oh my God. So got home, helped take care of my younger siblings, and had to sort of deal with all of that. And I think I prepared myself for it being cancer. I prepared myself for it being a tumour, which everyone in my family did. So then when we got told it was MS, I broke down. I was like, what do you mean it's MS? Like, that's an old person's disease. And it's really easy, I think, because you treat so many older people with MS to think it's an old person's disease. And so I had the stress of that and helping her get better. At the same time, I got married as well. So my sister literally got released from hospital a week before my wedding, and she was one of my bridesmaids. So you have all this built up stress. And then it got to second year, and I wasn't thinking of myself, and I wasn't working on my own health. So I've got ME, and I just ended up in a really bad relapse. My placement at the time wanted me to be in at 7 a.m. to 7 p.m. despite my reasonable adjustment plan, 4 shifts in a row, and I just didn't have that chance to recover, my body to recover, and I ended up relapsing really badly, started having blackouts and seizures, ended up with young person's hypertension. So I think it was 2 days before Christmas, and I went into hypertensive crisis, and I was at home, and my mum was like, "You need to go to A&E," and I was like, "No, I'll be fine. I'll drink some water. I'll go to bed. I'll rock it out." And it kept happening. So then I contacted my doctors, and they took it really seriously. I was like, "Oh, okay, it's not just stress then." Um, and I got referred to neurology. I got referred to nephrology. I had all the sleep studies you could do, all the studies. Um, and they couldn't pinpoint what it was. Everything looked fine. Everything looked healthy. And it's when my ME nurse was like, "It's because you need your reasonable adjustments plan redoing. The ward needs to be abiding by this. Like, they're not allowing your body the time it needs to recover. With ME, your cells don't recharge how someone's should. So I always say it's like a very first iPhone. If you were to use it for 10 minutes, it's going to take 90 minutes to recharge. And that's sort of how pace therapy works. So it took about a year, but I got better. I no longer have a young person's hypertension. It's gone. The doctors are, and my nephrologist believes it's because I worked hard to sort of recover my ME and really advocate for myself. But that was really scary because they said like if I'd left it any longer, I would have had a stroke, and they were shocked that I hadn't had a stroke. So at one point, my blood pressure was 230 over 200, which at the time is really high for a young person. Um, and I got quite embarrassed by that because when you think of high blood pressure, you don't think of young people, you think of old people. And for me, I was like, that's really embarrassing. I'm not even 30 yet, and I've got blood pressure issues. What's going on? I think it was a wake-up call. I needed to take better care of myself. So I've been focusing a lot on losing weight and being healthier and strong. I'm really focusing on my ME and being an advocate for anyone with long-term chronic conditions, and really enforcing reasonable adjustment plans. Because I think post-pandemic, a lot of our workforce now got long COVID. They've got autoimmune conditions. They've got conditions caused by the pandemic where they need these reasonable adjustment plans. And I think as an NHS, we're very quick to give parents and people who've had babies set shifts, but anyone else is a bigger fight and argument. And I'm not saying that parents don't need set shifts. I know they do, I'm the eldest of 10, but I think we still need that flexibility for people with long-term conditions. If we can give people who smoke 10-minute smoking breaks, we should be able to give people with ME or long COVID or MS or anything like that with 10-minute pacing breaks that they need, because, it's both fixing something. And during that time, my little brother caught whooping cough from school, and that led to FND. And my little brother is very disabled and special needs, so he's got chromosomal problems. So that was a big stress as well because I've always been very overly protective of him. I think when you've got a family member who has missing chromosomes and duplicate and broken chromosomes, and they're so special needs, and you've been told we don't know how long they're going to live, you do get really protective. So I had that going on as well. And I just thought, oh my God, is he going to live? Is he going to, what's happening? And I didn't feel like his hospital really taking it seriously. And then we found out like he's got heart stuff we're still investigating. So that was a big stress as well. And then at Christmas this year, just after Christmas in January, my nanny unfortunately passed away due to renal problems. She had I can never say it, glomerulonephritis. I work in renal, still can't say it. Type 2 diabetes. We didn't know she had diverticulitis either, but with her team at the time, because she didn't have a local renal team, they weren't taking it seriously enough, and there was a lot of things they were doing that was wrong. And I kept saying to my mum, like, you need to push this harder. I should be doing this, this, this. And I kept trying to get my nan to move down to where I am, because I thought, if you move here, you're under the renal team here. I know they'll sort this out. And unfortunately, just through a lot of hospital error, there was a lot of hospital error. And through I think my nan sort of accepted the fact that she wasn't going to get better, and she hid a lot from us as well. It got to the point where they're like, there isn't anything else we could do other than make her comfortable. And I will say, because it was a really awful experience. I think I spent a lot of my time shouting at the hospital, telling them off, being like, why have you done this? That's improper. When you get to third year, you've got one placement left. You essentially are ready to be a nurse. The final ward were amazing, who did her palliative end of life care. They went above and beyond. They let us all in. They let us have exclusive use of the family room, and we're a big family as well. They let my granddad bring in their little Maltese dog, because it was my nanny's baby essentially, so that she was there. They did the handprints. They did everything and anything they could do. They made one of the worst times of our lives so much better. So I think all of that, like, when I reflect on my past 3 years, it's been really hard. And when you sort of write it down and you look at it and you're looking at reflections and you're trying to talk about your journey to other students, you think, how have I made that through? And I guess it shapes you, and it reminds you of the person you want to be, the nurse you want to be, and you end up having a lot of experience with nurses as a family member or as a patient. It helps shape you. And it's probably aged me about 10 years.
So do you find all that experience with your late nan has helped you become a better nurse, especially working in nephrology?
Yeah. So my nan, I mean, she was 75 when she passed. So realistically, by today's standards, not that old at all. She was so proud. She was so proud that I was training to be a nurse. She would tell anyone and everyone, she'd go, oh, my granddaughter a nurse. I'm like, Nan, I'm not a nurse yet. Can we stop saying that I am a nurse? It was really hard because my family live in Lincolnshire and I live in Norfolk, so it's not like I'm there to do it all. And I am very headstrong, and I think it's one of my greatest qualities is that I can sort of look at even a family member as a patient. I'm like, this patient needs that. Why is it not being done? And with my nan, that at times did become challenging, and I think I've lived with a lot of regret for not calling out bad practice, which is something I'm sort of like still working on and coming to terms with. And it's really hard when you're a medical professional and you're there with your loved one being treated in a way that you necessarily wouldn't treat and isn't gold standard. But I know the good carers she had, I know the good nurses she had and how they made her smile, and I know the bad ones. And it's not necessarily that they were a bad person, it could be that they were burnt out, or it was their 100th person that week that they've gone to who is getting towards end of life. So I think it's taught me really not to judge a nurse by their mistakes, but think actually what's the bigger picture, what's going on. We know that we're in a safe staffing crisis. We know the NHS is struggling, and nurses really do support the NHS with their 24/7. So if anything, it's taught me not to judge someone on a mistake and really think about the bigger picture, which in first year I wouldn't have done.
Yeah, definitely. I think it's hard as well, especially when it's a family member and you are medically trained. You do start to question everything.
Yeah, it doesn't help that everyone else got lovely last words from my nan. Lovely last words. I got, please don't let me die. Thanks, Nan. That's great. That is
Yeah.
great to live with. And I remember going back to work as a HA on the renal ward 2 days after my nana died. I'd already scheduled my interview because she was poorly. And the clinical educator came into work, saw my name on the staff board. I was like, why is she in? Found me, saw me, pulled me into the storeroom, which was once the old bathroom, and gave me a hug. And she says, why are you here? And just being able to talk to her about everything and my regrets and how I should have done. She goes, and she said, stop. She goes, it's your nan, it's your family member. She goes, I've been doing this for 10 plus years. I still wouldn't be able to take care of my family member. And she sat down with me. She helped me come up with a plan of what I needed to do. And I thought, well, my friends are all in the training building across the road. I can go sit in a study room until they're finished because she didn't want me going home alone. I know that I need to get extension requests done for my assignments. I need to book an appointment with my personal advisor. I probably needed to book an appointment with my doctor regarding my mental health because of this. And she helped me sort of come up with that plan and made sure I got to the study room safely and had me email her once I got home as well to make sure I got home safe. And she kept in touch with me. And I've said, and I've said this numerous times, that moment for me was really pivotal because I think it did help me survive third year, but also remind me that I can't fix anyone and everyone, and it's okay to be human. But yeah, it's something I'm still having to deal with. It's something I'll say it's still very fresh. It's not even been a year yet. And there's times where I see patients who are poorly and they remind me a lot of my nan. And I just have to say, I just need 10 minutes and go and compose myself. And that's okay. It is okay not to be okay. And it's okay to cry. And I always think the sluice is a great place to cry in. And I think crying is therapeutic. I'm a big fan of a therapeutic cry.
So you've touched on it a bit there about your ward being quite supportive. How did you find going from student to newly qualified nurse, first day? How did you approach that change?
It's been really hard. I think so. At my trust, we do what we call a nephrology rotation. So you spend 9 months either on the ward or the outpatient centre. Then you go to the opposite place for 9 months, and you do that for 2 years. So because I've got loads of world experience, they've started me on the outpatient centre to start with dialysis. My first day, I was like a deer in headlights. I went in, I was so nervous because I knew some of the team members from the ward who'd done no rotations, but I didn't know that many of the team members, and I didn't know what to expect. I'm very fortunate. I'm very lucky that the nurse I was put with on my first day, I know from the ward. I was like, oh, thank God. Thank God. And he's like, we're just going to take it nice and slow. I'm going to show you how to line a machine, and that's all you're going to do for the next few shifts. I'm like, great, that's all I want. It's really weird. I think it's the biggest life change I've ever done going from student to qualified nurse because you have your preceptorship booklet that you've got to work on. At the same time, I've got my rotation booklet I've got to work on. Then you've got all the mandatory training to get done. But even though I've been there as a HA, you still got to redo it because you're a new role. Then get into terms with renal elements I hadn't even thought about because I've not worked on the outpatient centre. Getting used to your patients, actually reminding yourself you're a nurse. So I remember someone going, excuse me, nurse, I don't feel well. I'm like, oh, I'll go find you a nurse. So like, you are the nurse. I'm like, oh yeah. Even now, I forget I'm a nurse and I'll be like, oh, I'll go get you a nurse. And they're like, you're a nurse. Like, yeah, I'll go get you a more senior nurse. And I don't know, it's because I've been a HA and a student nurse with this department. I find times where I'm like, it's so easy to rely on the other nurses and go, I'm just going to get them to help. I'm getting better at it. I am coming up to 3 months in and I am starting to use my clinical judgment a lot more. I think I got to about 5 weeks of being supernumerary. It wasn't going to be long till I was in the numbers and I just hit a mental block. I was like, I can't do it. I need to be longer in supernumerary. I'm not ready. I suddenly became scared of AVF access and I was like, I can't do it. I can't access an AVF. I can't do buttonholing. I can't do the sharps or the blunts. because I'd had a really bad one, and it only takes one bad one to really shake you. So I asked for the extra 2 weeks of supernumerary, which I got, and I'm glad I did because it helped me. I needed it. I wasn't confident, and then when I got to the point of being in the numbers, I wouldn't say I was 100% confident, but I felt more comfortable and competent. And I knew that, okay, if I see a AVF fistula that I can't access, or I've tried it once and I'm not managing it, I'm just going to ask them to put pressure on it, take the tourniquet off and find a different nurse who's more experienced, because no fistula is the same. You never know what you're going to get. But when it comes to doing the lines, I love them, could do them in my sleep at this point. So there's that side of it, but it's also trying to fit into a team that's already so established. I'm autistic. I'm very open about being autistic. I think if you met me, you'd probably tell, like, yeah, she's autistic. And with me, I get a lot of social anxiety. I'm like, oh, have I done something to upset them? Why are they quiet? What are they thinking? Do they like me? Don't they like me? Have I done something wrong? Am I pleasing them? Am I being good enough? Am I good enough for this role? And I think you have the added pressure, or I know I have from my RCN duties and everything, knowing that so many nurses and student nurses now don't have jobs, and they qualified 3 months ago. And I'm thinking, why have I got a job and they haven't? And there's always thoughts going on in my head, and at times I'm like overloaded. I think I need to speak to someone, and I've got a great team leader, like my band 5 and my band 6 are amazing, and they're like, just chill, you're fine, you're doing great. If you weren't, you wouldn't be here now. And my band 6 always says it's okay to make mistakes. I'd rather you make mistakes because you learn from them. But it is a big thing, and it's going into a very well-established team of senior nurses who have been doing dialysis their whole life. And you think, oh, hi, I've come to replace you when you eventually retire. And don't say that to them, because I think I'd probably get shot. But it's really hard. It is really hard. And I've say this to a lot of the third years at UEA. When they ask me how I'm getting on now, I'm like, it's so hard. Like, unis don't prepare you for how hard that adjustment is, but you do get through it. And I love going to work. I'm on annual leave at the minute, which has very much been needed. But I really enjoy going to work. I enjoy seeing my patients. I know my patients. I enjoy asking about what they've done their weekends. You know, it's getting closer to Christmas, so I have this thing now every day when I tell them how many days there are to Christmas, and some of my patients are like, we're going to kill you. I'm like, yeah, I'd like to see you try. You're hooked to a dialysis machine. But it's nice knowing your patients, and I do love my job. It's hard. The transition is hard, but I really enjoy it.
So what does a typical day look like from start to finish for yourself on the dialysis unit?
So it depends what time I start, because we have different shifts. So my early long day starts at 7:15, finishes at 6:15. My short early it's 7:15 start to 3 p.m. and then you've got the long late, which is 11 till 10:30 at night, and then a short no, that's a long late, sorry, then a short late, which is 3:45 to 10:30 at night. So in the morning, I love my morning shifts. I think it's because then I get my evening free, so I can see my husband, I can sort of relax. But for me, I feel like you do more because you're doing 3 sets of putting people on and taking them off. But that first one in the morning, where you've got 15 minutes, you've got to line machines, you've got to make sure they're all working. If one of them's broken, you've got to quickly troubleshoot it. If it's not going to fix, you've got to find another machine to do. And then do the staff team meeting in the morning, the little huddle. That is quite stressful, those first 15 minutes, but then you're getting patients on. So generally, they come in, you weigh them, or they weigh themselves, so you know what we call their wet weight. So that's how much fluid's built up. And then you attach them to the dialysis machine, depending on their access, and their time, depends what order. So I always aim to do my 4 hours and my AVF access first, because they take longest. Anyone who's shorter, so we have some who are 3.5, we have some who are 3. They will be the last ones to be put on unless they've got an appointment, because they finish faster than the 4 hours, if that makes sense, and we have quite a short turnaround. And generally in my head, because I'm on the same team, I know who my patients are, so I can plan the night before in the morning, be like, right, I need to do so and so first, because I know their 4 hours and their fistula could be tricky. And then, yeah, so we do that. We do their wet weight. We have to work out how much to take off them, which is subtracting their wet weight from their dry weight from their wet weight, plus in 0.5 for their fluid allowance. But then not everyone's like that. So there's other things you've got to look at, like do they have any fluid buildup? Are they symptomatic? Do they have a wet chest? Are they telling you they don't feel well? What's their temperature like? What's their blood pressure like? Because all of that plays a factor in it. So you're still doing your A to E assessment when a patient comes in. If I feel like they look overloaded, I'm still gonna be like, right, let me see your legs, let me see your arms. If they're telling me they've not felt well, they're feeling really fatigued, if they've got a slight temperature, I know, okay, well, I need to do some bloods. So before I even connect them to the machine, I'll quickly do my CRP, my UNEs, and I might do a post UNEs to make sure that we're actually the dialysis is effective and we're getting those potassium levels down. So you've got that constantly going through your head. So even though I know my patients, I never know what they're going to come in like. I never know if they've behaved and stuck to their fluid allowance or their diet. And some of them are great for it and some of them are not great for it. And they know they're not. And they're like, well, I made it this far. I'm like, yes, that's because of dialysis. But you can't change a person. And then you do that. And then once they're on the machines, it's great because you've got those 4 hours where, other than medicine administration, which I don't do yet because I've got to do my IV study day, which is in a couple of weeks. So they have their meds round, you've got to put them on, you've got to sign them in on their computer. So we have a renal program called eMed that we use. So it's signing them in, it's putting in all their sort of like stats, so their weight, their temperature, everything like that. A little note to go with it if you're taking bloods, why you're taking bloods, like rationale. And then also if you think, okay, they've got a bit of an infection, just send in a message to the doctor to say, so-and-so's come in, bit of fever, feeling run down, we're taking bloods because we suspect an infection. Just so that the doctors know, because we very rarely have a doctor at the outpatient centre because we're not on site. So unless they're there for appointments, they don't come over unless we ask them. It's an absolute emergency, we ask them to, or it's pre-planned. And then midpoint round, and then that's it really for sort of 4 hours. Other than making sure they're okay, making sure you've done all your rounding if they're seeing her poorly. If we've got to get anything ready for the MDT appointments or any future outpatient appointments they have, making sure you're on top of all of that, chasing results on ice. And when you get to turnover where it's, okay, take them off, you got then, if they've got a line, you've got to lock the line with heparin or a similar sort of medicine to stop it bleeding, but also to make sure that it doesn't clot in the line. Because if a CVC is clotted, you can't use it and they've got to go to hospital. Making sure you're clotting off their fistulas, making sure they feel okay, checking their blood pressure again, making sure they've done their dry weight, making sure they leave in a fit and healthy way to leave, because we are essentially discharging them. And then disinfecting everything, because you've got to go again in 15 minutes and quickly. So I love it. I love those stressful parts because I vibe off stress, and I think for me that's really fun. You've got to quickly do it and also make sure your patients are safe and get the turnover in, and relying on hospital transport to be there on time, which they never are. That's usually one of your biggest challenges is hospital transport. And then you repeat that again. So we do 4 sessions a day. So of dialysis, so you have your morning, your lunch. Do we do 4? No, we do 3. I'm lying to you. We do morning, lunch, and evening. And then you might have the odd one who they've come in for an extra session, or they've got an appointment or a hospital appointment or an operation, so we've changed for dates, anything like that. Or if our acute ward is overrun, because when you start dialysis, you start at the acute ward because no one knows how your body's going to adjust to that. And then there's a waiting list to come to outpatients. So then we have some of their, what we call the inpatient dialysis, but they're having it with us because they would be going to the hospital to have it, but the hospital's full, so they're coming to us to have it, even though we're full. So it is a bit of a juggling act, and how the band 7s manage it, I have no idea. And yeah, there's always little tasks to do. So each team has their diary. So the first thing I do is I check what's been handed over, what's been left, check my emails as well for any referrals that have been made, because we have a renal counsellor who's on site with us, we have a dialysis access nurse who's on site with us, we have a home team. And at least 3 days of a week, we'll have a doctor there, one of our outpatient doctors. And I really enjoy it. I quite often, if I know my dialysis access nurse is doing something I've not seen and the team can cope without me, or we plan it in advance, like, oh, so-and-so's having this done, if I come in on my day off, can I watch it, please? And she's great. She's like, yeah, go for it. As long as the patient's happy, I'm happy. But also, if I look at someone's fistula, I look at someone's CVC. Like recently, we had someone with CVC that was quite ulceratively infected. I just said to my HA, it's like, can you just go grab the dialysis access nurse, please? I want her opinion because she's a prescriber. She's also, I think she's a band 7. You know, she's done all this training to get to that point. I know she's going to have the best ability to treat this line, and yeah, I think I love it. It is very routine based, which again I love, but saying that it doesn't always go to plan. We had a patient who got brought to us from a care home who was quite obviously poorly and needed hospital, but the carers and the hospital transport thought, well, they're going to dialysis, and I was a bit like, I don't know. It was very shocking. I went into it was my first poorly patient as a nurse. I got my band, my senior band 5. I was like, I need you now. Got him on oxygen, all that. We did all the basic A to E, and our unit manager made the decision we're going to dialysize him anyway to see if taking some of that fluid off would help. Then spoke to the hospital transport, like, you can't bring poorly patients to us. You need to call an ambulance because that's all we can do. And spoke to the care home and also said, like, if they're poorly, call an ambulance, not us. That was quite shocking. And I've like written reflections on it, but it is really weird when you get your first poorly patient as a nurse,
Do we
especially
know
that
what was wrong?
just fluid overload.
Okay.
I think because he'd only just started being weighed by his care home and just trying to get that right amount of fluid off. But say ideally someone wants 4 litres of fluid off, but you might not be able to take 4 litres off in 4 hours because their body just might not be able to handle it. And you know, we have a lot of older patients. I think my oldest patient at the minute is 91. If I tried to take 4 litres off a 91-year-old, I probably will end up putting them in hospital because it's a lot for their bodies to go through. You know, dialysis is, it is very brutal on the body. It is very subject to each person and challenging, and you never know what's going to happen. And, you know, even just having a bit too much fluid on your body is absolutely awful.
Yeah.
But yeah, he was
Well,
fine. And by the end of the day, he was fine and he was smiling back at me. He's like, oh, hello. I'm like, hello. Thank you for that scare.
well, it's been lovely speaking to you, Natasha. We've come to the
Lovely speaking
end
to you as
of the
well.
podcast now. Is there any social media that we can find you on that you want to talk about, or?
Yeah, so I have my Instagram, which is I'll just change my username. I believe it's newly qualified nurse Natasha. And then I've got my TikTok, which is the Chronicles of Natasha, I believe. I will double check that with you afterwards. And they're the two ones I mainly use. And then you'll probably see my face on the RCN website at some point because I do a lot of work with them and getting involved. But yeah, I'm primarily Instagram and TikTok. I know there's that new Lemonade. I've not really looked at it yet.
Amazing. Well, it's been lovely speaking to you,
Lovely to
and
speak
I'll
to you
see
as
you
well.
very soon.
See you soon.
Bye now.
Thank you. Bye.